Good morning, everyone. Um, we are going to start the meeting, and I will ask you to turn your camera on if you can, so we can start. Thanks.
Fabiola, the server says my video is not allowed to be on.
Now you can do it.
Thank you.
You're welcome.
Okay. Well. Well, good morning, good afternoon, good evening, good day, everyone. Thanks for joining us this day, where we're going to begin the town hall for one of our most important projects that we have been developing during the year, corresponding to capacity building and impact measurement. And now I'm going to welcome our panelists, our guests this morning. I'm going to begin by welcome Rosana Rivas. Thanks. Any opening comments? Welcome.
Thank you. Good morning and good afternoon, good evening, everyone. It's a pleasure to be in this really pertinent and valuable webinar, Town Hall, and I'm very glad to contribute them to exchange with my colleagues and partners in benefit of the output expected. Thank you.
Thanks. Now I welcome Shona Mulali. Hi, Shona. Any
Hi,
opening
Fabiola.
comments?
Thanks for the welcome. Not much more other than just to echo what Rosanna said. I'm looking forward to discussing some of the information that's come in from these two projects with everyone. So thank you for setting this up.
Thanks. Okay, I welcome Mr. Toby Clark. Good morning. Any opening comments?
Thank you, Fabiola. It's really a pleasure to be here. Looking forward to good results from this session. I think it's a very important one, and look forward to continuing. Over.
Well, thanks. Okay, now I welcome Mr. Antonio Hernandez. Good morning, Antonio. I don't hear you. We don't hear you. It says your mic is open, but we don't hear you.
You hear me now?
Yeah.
Believe it or not, experiencing some issues with internet lately in the they are changing the fiber optics. Anyhow, welcome from Washington, D.C. Thank you for inviting me to this town hall. One step at a time, I realize we are advancing, and I hope we could share today some information that could contribute to both of the areas, impact measurement and capacity building. Those are two areas that need to work together. It was great to have it together as just one topic. Thank you.
Thank you. Well, today we're going to discuss and share some insights about this project. And we are going to begin by comment some of the important points that were that arise from the work of the surveys that we released to you, and about the results that we got so far. We also want to discuss about the important insights that the theoretical framework that is supporting this project, namely the theory of change, and is why it can be helpful for us to develop our awareness about our capacity building and our challenges to training in our countries and in our regions. So let me share my screen by looking at the documents that we were receiving in the previous days. Let's see. Okay. 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 Well, as you know, we were using two important tools in this project. And okay, now Tom is now with us. And okay, I would like to give the mic to him. Good morning, Tom. Would you like to continue this, please? Can you allow Tom to use the microphone, please? Now you're a panelist, Tom. You can talk.
Yeah, sorry about the confusion getting going. But yeah, so that's a slide that we want to get to. Can you hear me okay?
Yes,
Okay.
clearly.
Yeah, with the change of the meetings, things got harder, but here we are. Can you go up? Let me see. Let me share screen. Can you enable the
Okay.
screen sharing? Can you enable the screen sharing?
Yes. Sorry. Yes.
Hey, at least we
Yeah.
got a good looking group here. I bet I need Toby to smile though. Okay, good. Thanks. Let's see. And hey, it's early. We enjoy confusion. Let's see. I'm trying to look at and nothing's working here. So in recap, we have the body of knowledge, body of practice survey. We have the impact measurement survey. And Saba and Shauna, I just sent in about 10 entries for the theory of change one with some documents, which I including some indicators from Toby, but a lot of things from Kaiser Permanente. It would be good on that survey, maybe if we could have multiple attachments, but I digress. I guess an overview of what we want to do is talk about both the BOK BOP survey, as well as the theory of change survey, the impact measurement survey, and then think of the implications of both of them this morning. And, you know, panelists were invited, and others that are joining us as they're able are invited from every region of the world. So we do want to get input from as many regions about how they might be able to use these tools to, particularly over the next couple of months, now that we're providing them. But I think we're still doing here introductory. We've got a bit of time this morning. I know some people don't, but maybe put it in the chat if you have to leave at a certain time, those on the panel. But I want to talk in a moment about the capacity building framework that is the Calroy and I put some finishing touches on it so far, and we've been talking about it for months. But I want to talk about both how well it may work and how well it might not work here in a few minutes. In terms of the BOK-BOP survey, this is still introductory remarks. You can see a couple days ago, we were at 550 responses from 121 countries. And you see the spread across the regions. In red are countries that are LMIC according to World Bank definitions. There's some observations from the global survey that we can begin to make. And we'll come back to this, just doing sort of a speeding by here quickly. And then, some discussions of where we go with it. And I assume we've sort of recognized attendees already. Let's see. And we've got, about half or more of our panel who have also been project leaders with the project, and I see friends from around the world. Thanks for joining. And I don't want to just focus on the body of knowledge, body of practice, which goes along with capacity building. Also want to look at the theory of change survey. I know we've got the architects of it here, and they did a wonderful job. When I was able to look at the responses here, there were a bit less. But we have some good examples, and even though Lee Ben and I articulated these examples, they're not about us. They're about the work of our colleagues here around the world that are particularly known. So we'll come back to that, and I think that's the kind of an overview summary. So I know we've heard from Antonio, and one of the things we had was the, let's see if this is going to come up. Yeah, I'm gonna try to pull up a PowerPoint here that shows our project leaders. I know Toby was speaking in to capacity building with Antonio, Fabiola, and Baron from Nepal. And of course, Shauna and George from Ghana, and who am I forgetting? Fabiola were leading with a lot of help from Saba. So, and others of you involved. I'm not trying to minimize anybody's involvement, because we were trying to get different perspectives, as you know. My computers are going to catch up with us here, I hope, in a minute. So certainly this work represents both CED and GCEA, and everybody knows that, so keep going here, Tom. Once again, computer, I'm awake, computers not so much. So anyway, I think we've sort of outlined who's on the project teams and what we've been working on. So I was going to try to show the project teams, but that may not be easy. So enough from me. Toby, some opening comments from what you've seen so far, and versus where we were 6 months ago. Toby, you've been working in the capacity building field particularly for a long time. What kind of progress do you see in this work, and what questions are still pretty wide open for you, perhaps?
Well, I'd agree with Antonio that impact assessment and actions are very closely related to capacity building. When you can show that impact, then the resources can become more available for capacity building. Basically, Antonio certainly set the standard working with PAHO in terms of reaching out and providing capacity building and showing the impact. I think, basically my experience has been in working primarily with Tahoe was to initially start with the basic education through webinars, etc. Then work with individual countries on focused areas of concern related to clinical engineering, whether that be awareness, understanding the impact of clinical engineering in general, capacity building, problems with regulations or disposal of equipment, whatever that is. Set those items up as what is your priority in your country. Then drill down through those workshops to come up with a focus. And using Shauna's example of DOC to have case studies that do show the value of clinical engineering. So I think all of this is going in the right direction. At that point, for instance, in Trinidad and Tobago, where Paul Taylor has really taken it up from there and developed a strong capacity building program and a network. In other countries, perhaps on-site activities to develop HTM plans for the country, providing expert input. Those are kind of my experiences working with Tahoe. But probably the most enjoyable part has been more the internship, and Paul has developed those in Trinidad and Tobago, and others have. So I just wanted to share that experience before we kind of move on here. Over.
And Toby, if we were to say, well, we know it's a bit of a complex topic and not trying to make it harder than it is. How do young clinical engineers get knowledge? And, there's obviously a lot of things included in this framework about capacity building. There's things missing. Certainly, I heard one word that internships should go in the knowledge bucket, is what I'm trying to say, because that's another way to launch. You get some education, you get some training, you're not ready maybe for credentialing yet early in your career, but internships are a wonderful way to launch you into a greater understanding. How about Shauna and Saba team up for a moment, about your initial thoughts? And it's really about, now we've got, we're beginning to unfold some data that we've collected. And by the way, I don't think I finished my sentence. And Shauna, hey, if I'm not awake, you got a way better excuse than I'd be 2 hours earlier than me here. Thank you for being here. Are we setting ourselves up to, to be able to do measurement impact with this kind of framework here? And is this data that's emerging, the BOK Body of Knowledge, Body of Practice survey? By the way, I showed a slide of 550 with people like Zhang Kun, who's online, Alan and his colleagues, Li Ben and others in China. They've got, a couple of days ago, they were up to 150 additional survey answers. So we're really over 700 responses, which is going to allow us in China to drill down. Maybe at that time there was 130 responses from 15 of their 30 provinces. So it's going to be able to help us drill down to the body of practice, even at the granular level of a province in a country. And Africa, honestly, Africa's response has led the world here more than not, in terms of number of countries and so forth. So anyway, we're going to be able to drill down to a pretty good level to see body of practice. But Saba and Shauna, some early thoughts?
Can you hear me? Thank you, Tom. Can you hear me?
Yes.
Hi, I think Shauna's had to go briefly, but she'll be back in a couple of minutes. So I'll kick off.
She probably needed a coffee break.
I don't. It's 2 o'clock in the afternoon, so I'm all right here. But she does indeed. I think we've been extremely pleased with the responses. And I think I need to make clear that the way we structured the data collection for impact, we knew that we couldn't probably get a lot of quantitative data, right? So data where we could do a lot of quantitative analyses, because impact often is about stories, right? And I know you can do impact assessment in a much more quantitative way. Many economists have tried to do it, and in other disciplines, they try and do it. We weren't yet at the stage where we had that data collected in a systematic way to be able to do that kind of impact measurement, which is why we opted for this approach, which is a little bit more qualitative in nature, but it gives us an indication of where we're making a difference. How are we influencing health systems more generally? What is the point of having clinical engineering if it doesn't make a difference? And those are the types of questions which we are beginning to answer now through the data that we have collected. So we're extremely happy with the responses. I can see that as of today, we have between 30 and 40 responses, depending how you count, because not everybody answered every question, which is fine. But I've got Bangladesh quite well represented, China, the US, Poland, the UK, Albania, right? So we do have a variety of health systems represented in the responses that we have so far. And then what we've looked at is to say, okay, which parts of a health system, which aspects of a health system have we really made a difference in through these stories that you've shared? And not surprisingly, one of the areas where we've had the most influence, it seems to be patient safety. So patient safety related to that also, there's quite a few responses talking about improved diagnostics, that this being an area where we've really made a difference. There's some other narratives that have been provided on how we've actually improved cost savings for our hospital, or we increased capacity management for our hospitals, et cetera, et cetera. Not surprisingly, given the pandemic we've just been through or are in still, emergency preparedness has been another area in which clinical engineers have also been influential. So that seems to be the big picture of where we've made a difference. Our next steps are to look into this data in more detail to then understand if there are any, I'm not going to say causalities that we can show, because the data isn't that type of data. I can't even show correlations necessarily, but what we can do is show causal links between what people did and what outcomes they had, what longer term outcomes and impact they had. I'm hoping that once we have that collected at a macro level for all the countries that are represented here, we then can use that as a way to then design a study which perhaps is a bit more quantitative in nature. But we needed to do this first. We needed to get the big picture of where is clinical engineering making a difference, you know, so that we can then delve down into the data in more detail and collect something which is perhaps more granular. That's my general overview and introduction. Shona, I know you're back now. Do you want to jump in with anything?
What you said was perfect, Saba. Yeah.
And Shauna, we were praising you in your absence. Go ahead.
Yeah. Thomas, is that sort of what you wanted in terms of an update and overview of where we are, or is there anything else we can respond?
Well, I think we're in the warm-up phase and the wake-up phase. And in our second hour, you know, I really want to get into the next steps and the way forward. But, you know, I think we're still setting the stage, but we're going to try to get input from each of the regions, particularly in the second hour.
Yeah,
and
I do have to leave.
Go ahead.
Oh, sorry, Tom. Just to say, Shona will still be here. I have to leave in the second hour. I had a prior commitment and a clash, unfortunately. So if there's any sort of questions about what we're collecting, then they can also be directed to Shona. We would still love more responses. So if I can make a plug here for more people to disseminate this survey that we have, then the more responses we have, the more complete the picture will be about what clinical engineers are doing around.
And a personal story on that, I started the survey 3 weeks ago, and it nicely holds my information when I go back to it. And then I was saying, and this isn't about me, but I added 10 more, you know, documents. So in other words, once you get into it, it's kind of exciting and it's great to be a part of it. And I'm so glad to hear that you're up to 30 to 40 inputs. Maybe what I'll do, particularly focused on the Saba, Shauna, and others show here. And I do want to hear from Alan from China and Rosanna here in a minute. But let me just tell you, you know, some of the good case studies that we have that are right in front of us. And somewhat serendipitously, Yadin and Khalil got got several of us involved in the program that's in Brazil today, actually, and started yesterday and goes tomorrow and beyond. But asked Lee, Ben, and I to talk about clinical engineering work and patient outcomes, which is exactly, I think, what we're talking about here. And, you know, this in his case studies from China, some of them are from his place there in Shanghai. His place, though, is 120 plus hospitals. So it's really it's a provincial health system into itself, where, you know, there's his quality control center makes sure that, I think, preventive and repair maintenance across 120 hospitals, and particularly some of the high-tech equipment like MRI in those hospitals, is standardized and, you know, well applied and so forth. Anyway, so it's very much around safety and quality of the high-tech devices that are used for diagnostics on patients. Also during COVID, there was this device infection control work, I think, particularly from the clinical engineering side. And also we know that WHO took our scope of practice during 2020 to now that was traditional medical devices, and particularly focused obviously on respiratory during COVID, included PPE in our scope of practice, oxygen sources, as well as oxygen driven equipment like ventilators and oxygen concentrators and so on, and digital health tools. I mean, we always thought we were in that space, but WHO put us in that space, particularly the last 3 years, which is very cool. And then Alan's study there in Hangzhou Pediatric Tertiary Hospital on safety and quality from a few years ago that I know that they continue to look at, alarm management, ventilators, and NICU. And then Lu Jiamin at the Red Cross Hospital, because of her incredible competence, has been promoted to a very high level at that hospital. But talking about digital health tools for patient-centered care. Quick side story, our beloved friend we lost this month, Mario Castaneda, and I had the privilege of going to Xi'an, China a few years back, and a pediatrician there said, hey, help me expand access in my practice. So we envisioned how Kaiser Permanente digital health tools could help a thriving practice increase its access. And, you know, and you can imagine, you know, as people check in at a kiosk at a facility, pediatric facility in this case, they could not only say what their complaint is today for their visit, but all of their health record would be there right there in front of them. And so the people serving them, the doctors and nurses, would know not only what they needed today, but what they had going on when they came in, what other things preventive tests might be able to be done while they're there. Then they go to a facility. I'm trying to start my video another way, but thanks. And then they got evidence-based care while they were in the doctor's or in the treatment office. And then, but there was communication through, in this case, social media, WeChat in China, you know, before, during, and after the visit. You know, maybe they didn't have to come in because of social media contact, WeChat with the doctor and the nurse. They said, you just need an increase in medicines. I mean, all those kind of digital health tools that we said, if you applied Kaiser Permanente to a clinic in China, actually, Lu Jiamin at the Red Cross Hospital in Hangzhou, within a few years, was doing exactly all of those things. And so that's what's that particular case study. And it's in the context of what we, the clinical engineering community, had figured out a few years earlier around our success stories, 400 success stories from 125 countries that we've published, that these are the right categories on the right. You know, what are our impact on patient outcomes? They come through innovation, through increases in access, through, as you were saying, Bangladesh, now you have a good sense of their health system, safety and quality, HTM, and we called it e-technology, but it's really digital health. So I'm showing quickly the China stories, and I'll get Shauna and Saba and others to react. But you know, here's the large health system. What did they do? They established standards, common working guidelines, 50 related institution norms, templates around all the purchasing and maintenance and management, and then training and regular inspection. And then incredible work around data management and asset management related to that. Okay, and then, you know, and then they measured, you know, calibration and appropriate MR maintenance and results over time. And then, okay, so this is the next case study about infection control and how to handle equipment with COVID patients all around in ICUs. They more PPE stuff, as I was talking about, many quality control centers. So a context across a health system in which all this best practices could be administered. Here's Zheng Kun's work. I'll have him respond to it too. And here's Liu Xiaomin's work around increasing all the digital health tools to optimize care from check-in through care delivery through after departure. So let me stop. Alan, you want to comment on those first from China, and then maybe Saba? And in other words, are we hitting the mark? This is the kind of patient outcome stuff we want to be talking about, I think. Alan?
Yes, thank you, Tom. I have to say, you obviously know more details than I. I have nothing to add, but I also want to tell you a success story about the medical equipment quality control in my province, Zhejiang province. My hometown, the Zhejiang province, there are 11 new cities and the province. And so the reason I said we have pretty successful medical equipment quality control program to cover the whole province is we established the 3-level networks. That was that is the provincial level. There is a provincial medical equipment quality control center, and then the 11 cities, all in the city level. There is the city level medical equipment quality control center, and underneath the city level there is a county. We call the county. And there are a lot of the small hospitals and also some of the clinics. Through this network, we mainly to cover the whole province territory. And I think this is quite unique in China, in all the 31 province in the mainland. And
How many
by my knowledge,
how big is the population?
province.
I know it's huge in Hangzhou region.
Hangzhou is like 100 million. Let me see. The whole province is 40 to 50 million peoples. And Hangzhou, the capital city of the Zhejiang province, let me see, it's 100 million. Yeah.
Very good.
Yeah.
Saba, Shauna, Saba, I know you don't have too much time. Thoughts about what you're seeing? Are we hitting the mark?
Yeah, I think that's an amazing set of data to have, definitely. And I think we can incorporate that. I don't think that data is in our survey, but we can absolutely get it added because it looks like quite a large data set, which would be wonderful.
So we want to blame you two and your team for getting us to tell these stories that you've asked us to, and I want you to be encouraged that there's incredible stories out there.
There's wonderful. This is amazing. I mean, if this has not been uploaded, we'd love to see this one uploaded also. And you could always email us extra attachments if the survey doesn't let you attach more.
And I know since Alan's backyard's a big place, so the Shanghai region, I might not even be saying it right, is here in the upper right in the Hangzhou region just below it. So, but 2 of 31 provinces, I believe. All right, some other stories. Let's see if I can. Yeah. And so once again, this is just setting the stage that they come in these 6 categories. And some of these stories we might be a little bit more familiar with. This is Dan Clark's work from UK on oximetry at home. And I think many of us know the story that if you intervene earlier with accurate oxygen saturation on people at home, if they knew their oxygen saturation, excuse me, accurately, they can go in and get care quicker, and the longer they wait, and as the oxygen saturation decreases, the more mortality, the less good outcomes. The problem was UK and its enthusiasm earlier on put out inaccurate pulse oximeters, and that's the kind of the middle slide data. But Dan and his team, I know he was in Nottingham, but once again, one of the promises of many in UK, but he said to the National Health Service leaders, we've got to do better. We got to have more accurate if we're going to send these home with people, and that's going to lead them to measure daily, but then decide to go in and get care. They might think they have 96% saturation. They actually have 92% because of inaccuracy, and that 92 is almost beginning to be too late to get care. So when they got more took the inaccurate pulse oxes off the table, put accurate ones out there, patients were able to get themselves treatment quicker, and they got better outcomes. So if that story's, I think Dan's story is in there, but there's other stories from Dan in UK. I know he had one about ventilators, particularly also. And quickly, and then I'm gonna get a response. This is AMTZ, and we know that they just had this amazing story that many of you have heard before, where before COVID, they put into place policies so that they could bring the 110 plus manufacturers together there at one site and share appropriate resources through policy. And then during COVID, because they had that incredible platform, like it says, they were doing, at the height of COVID, 200 ventilators being manufactured a day. That was 3 different models, by the way, and they all had to go through the EUA process, and that took more than a minute, but they did get them, and they were producing 200 ventilators a day, 1,000 oxygen concentrators a day, 100,000 PPE or N95 masks, 5,000 PPE kits, 1 million IVDs a day being manufactured on their site. Then what did they do with all this? They sent oxygen concentrators, once again, out to the public, kind of like the pulse oxes in UK, through 80 different cities across that country and warehouses in those cities that were also repair sites. And then from there, they were sent out to the patients for $5 a day. Anyway, very affordable, apparently, for many people, not everybody in that country. And then they also did creative things with all these oxygen concentrators. They were bringing them into the country from importing them in, but they were, as well as exporting and giving away. But then because they had credentialed 1,300 CEBMEs before COVID, they were able to place them at these warehouses, repair facilities, and maintain imported oxygen concentrators. And that they continue to do things as a WHO collaborating center that they were named this year, like prosthetics. They're able to 3D print a prosthetics for a specific patient at a specific time at 10% of the cost typically. So just an incredible story that, can't even think about all the implications across that very large country. And then, a favorite story here is Ray Dalton. Many of us in the US know of Ray and his work, Parts Source, that his for-profit parts company across many things. But he's gone to other countries like Haiti, like Rwanda. In Haiti, he has used digital health tools to map the whole country in terms of what hospitals and clinics have what kind of providers and what kind of clinical services. Not to mention, is there internet access here, and is there, electricity and so forth. And then now that he knew where and who all the practitioners were, he equipped them with kind of beginning tools that were sourced in Haiti, for beginning triage of patients. And then he took a whole sector of the country, and it's this bottom part, a slide, the northern Haiti, which is, X numbers of hospitals and clinics. And it could have been this 35 hospitals and 80 clinics, I believe, and standardized equipment across them, trained the biomeds, and worked with them around devices and around oxygen sources. In fact, the Global Clinical Engineering Alliance honored one of their lead BMET trainees as the BMET of the year for globally Evanel Osias, Pignon, for those of you that were in yesterday's meeting, is at the bottom of this orange at the top in the northern sector. So they're training people. In fact, during COVID, you know, us Blancs or gringos couldn't get into the country for reasons that many of us know, but the biomeds there took over and did a wonderful job. So once again, Saba, Shauna, I don't know if you know about these stories, but some amazing stories where here's a place where you're not only training people, but standardizing the medical equipment, standardizing the ability to get repair parts at very low prices, create service centers, regional service centers in the country to operate out of, and really something, it's almost like the silver bullet of capacity building capability for LMIC that we've been looking at for many years. Well, they're implementing it. Ray Dalton and people like Evanel Osias are implementing it in a country. Over. So Sab and Shauna, these are some stories that to me are some of the most impactful across the world. And others can respond, but I wanted to give our impact measurement leaders a voice if they would.
Yeah, I agree completely, Tom. These are amazing stories, amazing data, like large kind of areas that are being looked at and really specific information about what happened, like what the activities were that have led to change. So I agree completely.
Yeah, I think what's interesting about this, Tom, is that in terms of health system strengthening work, a lot of effort, research, and even research funding goes into the capacity building of clinical health workers, right? Whether there's community health workers in low and middle income countries, or if it's physicians or nurses. And there seems to be much less attention to the wider infrastructure of a health system where clinical engineers have a huge impact, right? And to making sure sort of, it's that phrase, the hidden heroes of COVID, right? So the back end, the organizational domain of health systems gets less of an audience, less of a voice. And here we have actual data showing how essential these services are and what impact it can make. And I hope this is also in the response. If it's not, it should be. I've just increased the number of attachments to 10. So now we can add loads of attachments. Sorry that wasn't, I didn't even notice that was a limitation before. But please continue to provide this, and we'll use all this to make a wider narrative about the impact that clinical engineers are having for health systems.
And by the way, yeah, we've got our own problems with the body of knowledge, body of practice. Somehow some countries were left off in the list, which of course doesn't encourage people, but Australia, New Zealand, and the country of Georgia and others. So just bear with us as we perfect our tools. Rosanna Rivas, you have been with Toby serving in Haiti. You want to tell, your perspective on Haiti from what you've seen.
Thank you, Tom. I rather to start with the point of the survey and the objective of this, the main objective of this session, please. 50% of persons who answered the questions were under 40 years old, and 50% we are more than 50 years old. It means that the outputs expected should respond to the needs of adults and young people. Second observation is about the need in low-income settings, the strong need of quality, safety patient, and training, as well as understanding and improve the use of medical devices. I wouldn't say just complex medical devices in general. I wanted very much to share with my dear and estimated colleagues that these results are very close to the reality. The reality is much more, of course, detailed from the numbers, but the numbers certainly help to understand that now, before the pandemic, but now in the pandemic, since the pandemic, these issues are urgent to be improved, and the sense and the interest on having a theory of change or BOP or BOK model for everybody of us is how to use it in effectiveness, how to use it to make solutions to improve what we are doing in the site. I am very glad about the efforts from Shana and Saba in this very important survey. I want to express my gratitude for both to lead this important project, because this information is very valuable to WHO Adriana to connect with the, I'm not saying not to the developed countries, but with the developed countries, much more with the not developed countries, please, because these are issues urgent to be addressed. Talking now about the stories and being connected to the first observations I liked to share. I believe that with my all admiration to the China fabulous development, is so interesting how they are able to approach the regions in such important and effective way. And I really like the case of India. It shows very much, not just to Latin America and the Caribbean, but also to Bangladesh and other countries from Trinidad, Tobago. We are low income, we are with a lot of basic needs, but we are also able to develop medical devices, to import, export, to be a good example. So for us, India is in particular a very special case to analyze and to make benchmarking to that. Finally, to Haiti, and it's not because it's not important, but I learned very much, and keep learning very much about expertise, ethics, and most of all, how to contribute working with Toby and collaborating with him in the WHO Collaborating Center for HTM in the University of Vermont. And not just in Latin America, but in Haiti, when we work in French, when we did this course of combination of HTM, HTP, but also innovation applied to medical devices for them to improve their own solutions. I believe that this is a sort of a very golden, for me, example of how the evolution of these online courses, which I've been teaching more than 15 years over some countries, the evolution can improve not just for the quality of the teaching, the training, but also to the outcomes expected. Haiti, they were in the middle of confrontations, wars, civil wars, corruptions, the COVID-19. And Evenel Osia, since the very first day, he was very collaborated. He was amazing, helping us, supporting as a leader, also as a tutor of the course, to improve the outputs, to collaborate. He is a very well example of how many leaders are in the low income settings and waiting for this type of connections and trainings. I'm sure this survey will go beyond the numbers to the next steps that are very expected from all of us. Thank you.
Thank you. Other comments from the panelists?
I just wanted to jump in quickly and say, Rosanna, you're much more articulate than I am at this time of the morning, and I think you're only an hour ahead of me. Thanks so much for your reflections that you've just shared. I agree with you completely, and I think you've really highlighted the relationship and the kind of interplay between capacity building and impact. And we very much want to see those stories from low and middle income countries, from lower resource settings, because you're absolutely right. There's so many good stories about impact, and the impact can be quite big when we're talking about situations where people start out with very few resources or very little support. in their institutions or their healthcare systems, and then they are given those resources that they require to do their job. They're given the training, and the impacts can be seen quite tangibly. Just sharing another example that's it's one of the examples that we used in the mini workshop that we did on the theory of change model. In Zambia, there were some recent graduates from a BMET training program that went to work, 8 graduates that went to work in 8 district hospitals. And over a period of 8 months, they collected data on all of the repairs that they did or tried to do, what they needed to do the repairs, and what the outcomes were. That was called the Medical Equipment Uptime Project in Zambia. It was a partnership between the college, Nortec College, the NGO THET that does a lot of capacity building and training of healthcare workers, as Saba mentioned. And as we all know very well, our type of health professional is not always thought of in terms of training or capacity building but actually the impact that we can have can be quite large. And that's another good example. So it showed that equipment uptime went from 71 to 93% just with having those trained BMETs who had the knowledge and had toolkits and test equipment and some basic spare parts to do the repairs in their hospital. So yeah, I just wanted to thank you for your insights, Rosanna. You've really kind of highlighted the importance of us collecting stories from lower resource places and the value that those stories show, because the impact can be quite large.
Others?
Yes.
I see that hand. Go for it.
I was very touched by all those examples, basically in capacity building and how to impact the health of the population. And I want to share quickly an experience, because I think if you look at careful, you always have an opportunity to improve outcomes in health. And when you are in the field working, you have a lot of opportunities. Shauna, she will confirm that. And what I am talking is not about high technology, but more going to the basics. My experience was related to the immunization program in a country with a very well-established health system. I'm talking about Costa Rica. Everyone knows that they are very proud with the health system they have. However, when we started looking very careful, we realized that the coverage of the immunization program was around 92, 93%, totally unacceptable for the level of the healthcare of the country. And we start studying the reasons why the coverage were so low, because they have the supply, they have the resources, and they have the people. And then we realized that most of the rural immunization programs in the hands of the health workers were done using motorcycles or outboards. When the health workers were hired, normally young women, they just give all the instruction, they give all the devices, explain the integrity of the cold chain for the vaccines. And last but not least, they give them a set of keys for a motorcycle, not even asking if they knew how to drive, much less how to maintain. Well, let's see that not knowing how to drive and how to maintain, the lifespan of these motorcycles were between 6 months and a year. And most of the time, they were not doing the work because they didn't have the tools. And all what we did was just to have a training program for driving, basic maintenance, safety, and a couple of central workshops for more complex maintenance. In a year, the immunization program statistics jumped to 98 to 99%. It was a huge impact. So, and something similar was happening in the rural areas where they use the outboard motor for going in the campaigns. The motor were not working, and then there was not immunization, plus other health programs that were carried out by the teams. I have some very comprehensive video on this, unfortunately not documented in writing, because when you are in the field, you don't have too much time to do that. But as I say, if you look at careful, you always have opportunities.
Thank you,
And-
Antonio.
yeah.
So what I hear is there's a lot of the world that's in a rural setting. You know, how do we help people get the technology access there? And, you know, a motorcycle and the ability for Wi-Fi or cellular at somewhere along the way to help coordinate things. There's a lot more that can be done, is what I hear you saying.
Exactly. There
And,
is
you
always
know, maybe you
opportunity.
can, you know, fly things in through drones. I mean, that's why, you know, we all have our personal favorite story. This one's not about me. I mean, the Ray Dalton story in Haiti excites me because there's, you know, they're opening up that creativity, and it's not just about the people parachuting from the outside of the country into the country. It's really enabling the people inside the country, and which is your story also. Put those community health workers with motorcycles, you know, teach them how to be able to use them, and then a lot of incredibly good things start to happen. I'm going to move on, but I think that's been a great introductory hour. We want to get to some. So what are the next steps here? Quickly, I'm not going to beat on this model too much, but you know, there's been a lot of input, and you know, can we, you know, frameworks are powerful is what I guess I'm trying to say, and that's Milan Paluta from South Africa, our colleague speaking. He's always pushing us to have frameworks, because out of frameworks, you know, we account for many systems factors, and we're the systems thinkers. We're not the only systems thinkers in the world, but we're among the best for healthcare. So, you know, are these the right buckets? And, you know, I'm not trying to grade this framework right now, but I'm also challenging us to fill in the gaps of the framework. And I think Toby's mentioned one other gap in the knowledge bucket, but under knowledge, we've got education, particularly academia, your academic preparation, training that comes from many sources, continuing professional development, CPD, or CEUs, continuing education units we call in the US. But we all get ongoing training from one source or another, you know, industry or universities or, you know, private, whatever. Credentialing is part of the knowledge bucket, certification, registration, and then increasingly in recent years is the kind of thinking Antonio was just displaying that they did in Costa Rica, innovation. How do you use what's available to you and make it better? And of course, all the digital health tools that improve devices and clinical and business workflows. Investment, you know, that comes from the outside. That helps us get going is, you know, are we in a country where the NGOs and industry donate things and lead things? Or are we in a country where the Ministry of Health and universities, maybe in the private setting, drive things? Where are the devices coming from? Donations or, you know, purchased through planning at some central source like the Ministry of Health? Is there investment in CE departments, facilities, and test equipment and tools like inventory management that can drive things, and then are there added value activities where we invest to improve? And then competencies, are we working with the most complex, how does that involve service delivery management, preventive maintenance, repair? How are we working well with the doctors and nurses and the other allied health people around us? Do we have a society? And are we, at the higher end of competency, are we affecting policy, regulation, and legislation? We've got the policy leader here among our participants today, Elliot Sloan, who can perhaps say more about that. But you see in the low, medium, and high setting, particularly focused on LMIC, sorry, he's getting a call. And anyway, and then how do you move between these status levels? And some suggestions are here. And are you part of a developed country? Well, maybe there's a fourth category for the high-end tertiary hospitals, like in the US or Italy or some places. Once again, we've seen this before quickly, that, yeah, we had 128 countries come to the register for the Congress a year ago. We're going to exceed that number of inputs of countries into this survey. What has it told us? That globally, 50% of our profession is under 40, nearly 50% has less than 10 years CE experience. It shows the degree mix globally and a huge growth of global digital health involvement. And oh, by the way, this survey has been done a couple times before, 2010, 2017. We added questions about digital health because it's all around us. What can we say about regional differences? And maybe the slide will go down here in a moment. We've begun to look at that. Please go down. And we see, and all of you, I think, have this, whether I can get it to move or not, is that, Africa is younger. It has people less time in the field. I'm memorizing that next slide. They want to get involved in digital health. They need credentialing, and so on. Yeah, driving me crazy here. Let's see. And then we dove down deeper in regional differences as well. I hope I'm going to be able to show that here in a moment. But this is the kind of things that we can do looking into this data. And the truth is, it's not about us, here we go, looking into the data, us maybe in CED, GCA that are in the leadership roles. It's really about putting this data in your hands and letting you look at it. So here you see globally 20 to 40-year-olds. Ouch. I had it for a moment. So hard to speak from the script when the script's not there. Let's see. Oh, I think that whole thing shut down. Let's see. Can I come back to it? And Eugene, welcome from Rwanda there. Let's see. Here we go. Maybe here we go. Well, while we're waiting, hopefully for the slide to come up, I'm happy to say when I look across who's at the meeting today, what are we trying to accomplish with this meeting? Not just kind of sing our praises, and remind ourselves of more and more stories, but we're trying to really decide where to go next. Let's see if I can get our story back up here. And, we gave the regions that, when I had the privilege of leading CED, I think we had the regions come together this year once or twice, but then Fabiola's wonderful team has had the regions meet a couple times. We wanted the regions to say, what's next, but we gave them an impossible job, really, of saying what's next, because there's just too much data, there's too much complexity. But I think we're giving them, with this survey data that, in the sample sizes that you're hearing about, we are going to be able to give them better data, our data that is actionable. And it looks like I'm not going to be able to pull up some of the things I want here easily, but that's all right. Many of you have looked at these slides that we provided to you. You see that you can start to tell regional differences. If you have enough data across a region or across a country, and by the way, maybe you heard me say that the African region actually, Ghana has had like 25 inputs. So, there's 30 countries from Africa that have submitted. Several of them have 15 or more inputs. What does that allow if we share the data back to you, to the Africa group? And by the way, the Africa group is, and I'm talking about those that WHO would call in the Afro region. They're out of Brazzaville, Congo, but there's 50 countries according to WHO in that. We CED and GCA have close ties. We have ties to all 50 countries through various health technology leaders, but we have close ties to 25 of those countries. Particularly those 25 are forming themselves into the Pan-Africa Clinical Engineering Federation under Ashnafi Hussein Ethiopia's leadership, and with the help of many others. And so when we give the data to Ashnafi and that team of 25 countries, and then even give them country data, they can begin to see where countries are on the, so here's a look at the countries. There's 27 of them so far. What's interesting is, the 3 countries according to the World Bank that are not LMIC, Botswana, Namibia, and South Africa, all the others in red here are seen that way through WHO because of the economics in their country, not a put down. It's a analysis. Places like South Africa and Maladen Paluta, Mohammed Berra, and others, with their National CE Society, KISA, CEASA, who met this week. KISA is a very established national clinical engineering society in a country that has more resources than many others around it. And they are committed to helping those countries around them. And so what am I saying is that this Pan-Africa CE Federation of 25 particularly active countries on this list, but you can see there's more countries that are less active, but maybe in becoming more active. We've got, anyway, it's very cool to me that that's happening, is that they'll be able to take this data, drill down, and help people see where they are on the framework list that we were showing a moment ago, and see what their gaps are, and then have very actionable next steps. If one country doesn't have an academic program, we want to make sure they have help them grow and build their national society. Their society can help people maybe go to that next country over to improve their academic background, be able to share training resources, continue to, work top down with ministers of health, that we're getting more and more current and previous ministers of health on our wider board and collaborator global CE community team here, so we can speak into those countries from top down and bottom up to encourage them knowing their gaps and working on ways to fill their gaps in knowledge, investment, and competencies. So it's kind of a mouthful. Let's see who. I know. Let me pick on you, Ladina, and maybe you can, Sam. You can activate, or Iris can activate her to see where. And she had to go, but Iwa, talk about in Poland, maybe how you can use these kinds of tools. If we had data across Europe and we had data from Poland, how might you be able to change capacity in Poland? Or how might Poland help the countries around it? And I'm going to pick on others of you in the attendees today. Maybe you can, somebody can invite Iwa, can activate her ability to speak. And maybe while that's happening, and also activate Courtney Nanny. Courtney, how can you imagine this could help Nicaragua? Go ahead. I hear somebody about to speak.
Tom,
Yeah, go ahead.
yeah, could you show the slide of the framework of the maturity model? Yeah, I have one comment.
Please.
Yeah, and the investment, the C department, should we also take the staffing level into consideration as one element of investment? You see the C department, you
In other words,
mentioned
do you have 2
facilities.
or do you have 200 people working for you? Yeah.
Yeah, the staffing level in the clinical engineering department is also very important. It should be appropriate with the responsibilities the department takes, and also should be appropriate with the scale of the hospital.
Right. And
So, I
I
will
think why
suggest
it
to you.
wasn't included so far, but we should, and you're right, is because
Yeah.
it has to, the number has to be set in context, right?
Yeah.
Is it a 200 bed hospital? Is it a 500 bed? Is it 1,000 bed? You know, it has to be compared to what it is they have to manage somehow, but you're right.
Yeah. And another thing, another comment is about the advanced level of the CMMS. And you do mention the advanced model. The CMMS should include the digital health and cybersecurity. But also another element is also very important is the data sharing capabilities. That is to say, the data is not only available within the clinical engineering department, and we also should measure the capability, the data sharing with other departments, such as financial department or some of the clinical departments.
I think that's a very good idea. And you know, we clinical engineers need to know how to articulate that data and arrange that data for health leaders.
Yeah.
So to show that, yeah, we can improve access. So
And
we can-
also through the tools, not only the oral communication or paper communication, should like through some of the data interface to interconnect it with the other hospital systems and to allow the data can sharing between the systems and even help for the decision support.
Yep.
Yeah. Okay. So that's
Thank
my
you.
comment. Okay, you're welcome.
Anybody ready to speak? Shauna, how could you use this in, you know, in Canada, in Northwest Territories? Maybe as a question. You're clearly a developed country.
Oops. Yeah, definitely. I think
But you also have had a lot of experience in Africa, and you may, you know, you can think about how this applies to Zambia or something.
no, for sure. I think yeah. I always appreciate a good framework. So my brain is happy when I'm looking at this and hearing you give an overview of how it was developed and how it can be used. Yeah, and it's always interesting to see what the similarities and differences are between high and low resource places. Definitely. I mean, it's also interesting. So yeah, where I'm working right now in the Northwest Territories in Canada Canada's a very, very fortunate, well-off country. We're a high resource country, and yet we have some challenges in our health system here that are very much like challenges faced in very low resource settings. We have a lot of small communities that are fly-in only. They're hard to reach. And we have major challenges with recruiting and retaining nursing staff. For example, at the facilities, we have major logistical challenges getting our equipment and supplies in and out. We have some kind of higher health burdens with some of the communities here than other places in Canada. So, but yeah, I think that this framework is very useful. I think it's good to have one that kind of captures a country or a regional perspective, but also includes data that could be looked at within an institution. And I think it's always interesting to try to link capacity in terms of number of trained personnel with certain qualifications to the actual activities that they perform, both in their facility and in their region or their country. I also think in some countries that are in the process of building up their capacity in this area, it is always very useful to have concrete stories about impact and data about impact, and to have models like this when people working in those countries are trying to advocate for funded positions for our profession, because that is also a big challenge. Certain places that I've worked, it's obviously quite a big thing to get a training program up and running, whether it's on the job training or a diploma, a degree program, and then often following that, there's a big challenge actually getting funded positions within the public health system, for example, for the graduates of the program, and having this type of framework and model that can speak to that is quite useful.
I think you said at least two brilliant things.
I
And-
don't say many brilliant things, let
And-
alone before 8 a.m., but thank you.
No, but I mean, it's linked the framework to our outcome stories.
Yeah,
I mean, that's kind of a duh, but I mean, what a good idea. And then maybe put them alongside, hey, I'm trying to increase my staffing with, blah, 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 and get, a case study or two around that would give practical tools to people to take the next step.
yeah.
I love it.
Yeah, we're very interested in, we're very interested in looking at, trying to link what comes out of these two. We talked about that, I think, many months ago in the spring when we were trying to put some shape around how to approach these various projects, that there's a reason why we're having this discussion about these two areas today. Obviously, capacity building and impact measurement are very closely linked, and it would be great with these data sets that we're gathering to be able to show some of those linkages.
And while we're talking, I'm asking, can we promote Iwa to a panelist so she can speak as well? Other thoughts while we're doing that from the panelists? You're gonna have trouble matching Shauna, though.
If I may.
Yes.
Go ahead,
Sorry.
Fabi.
Okay, thanks. Well, briefly, I can watch some important things over the statistics that you showed. First of all, is that there is an eager to be educated and trained on the capabilities of being a clinical engineer. But also I have to consider that the context of the different regions are very determinant when we want to improve and we want to apply it into the practice. So the data that the survey is providing is very, very enlightening if we try to analyze it under the context of the different regions and even among the regions in the different countries. And the other point is the profile of the clinical engineers that want to be trained show me that it is a very we have a very high expectations and a high level of hope that if we want to operate a program, even in the region or in the country, the response will be very positive. What we have to do from the CED, from the countries and the societies and the groups is to make some noise in our Minister of Health Environment in order to them to listen to us, to watch us, and to see the value that a very well-trained engineer can provide. And how can we do that? Well, first of all, by analyzing, I repeat, and I'm sorry for being repetitive, but by analyzing under the context this information, and the validation of this will be will release very insightful points that can be addressed to implement the training programs and the other capacities that must be learned besides the technical ones, the questions in the questions and answer that is saying that there are more than technical things that we must address, but I think we have to do one step at a time, but by beginning by doing this will be very, very important. Thanks.
And just before Toby and Antonio speak, I can imagine, Fabi, particularly from your academic view, and Somib and college in engineers in Mexico, connecting with Roberto Ayala with his Senatech background across many parts of Mexico. You could imagine how could this framework help your developed country take the next steps.
Yeah, but we have also another reality. I'm sorry for the insistence, but the context is very important. And Mexico has a very, very complex geographical characteristics. And this is a very important determinant on the development of the capabilities, not only of the biomedical engineers, but also the professionals. So each region
150 different ethnic groups in your country, something like that.
No, and 200 million people living here. So we are trying our best, but what we are also trying is to organize as a society and as are the colleges to provide the best quality capacity buildings that we can to all the eager young clinical engineers that wants to be trained. And this is the importance of the projects that we are talking on this week, because this project is going to be linked with the policy one. Yeah, once we have this information very well analyzed and we get to our conclusions, we may proceed by talking with our decision makers and our ministers of health to provide evidence to or the value. So this is why the theory of change survey is so important.
All right, we stirred up the panelists pretty well. Antonio, I think you had your hand up first.
Yes, thank you, Tom. I mean, this discussion or this panel has been very rich, but talking about the book of knowledge and the book of practice, one of the important values is that for many years, especially the last 10 years, we have been putting a lot of effort through different meetings and conferences in having the priorities for the clinical engineer, for the health technology, and how to improve outcomes in the countries. There was a bias in all those priorities. First, there was many priorities and never knew clearly what was the more important set of priorities. And the bias was depending on the participants. However, with what we have now is a more homogeneous knowledge, and that has given us better information of the priorities, and that is the first important product. The issue comes is now we have the information, how we transform that information into action, and that is our first challenge. The second challenge is how we scale up all these possible activities and programs. And it comes a point when who is doing what? I, as an engineer, what is my area of influence? Could I influence my colleague, my group of colleagues, my institution, my organization, my Ministry of Health, or my country? And you could do it at every level based in your position. But that is the starting point. And it comes something very relevant, and I call here our dear friend Mario Castañeda. The last 5 years, he was working and advancing the idea of the need of have educational programs for leaders. We need leaders, and I think we need to continue in that path. And also the need of mentoring. We need to have mentors who help the coming generation in advancing all these ideas. I think that is very important if we are really talking about capacity building and impact measuring, something that we could do on every level. But just remember, today we have information, but I got here my friend, Dr. Enrique Ruelas from Mexico. He always mentioned technology is a mobile blank. When you reach there, it has advanced. And I will say both knowledge and practice and the information we have is a mobile blank. When we reach there, things had advanced. It's a continuous movement and advancing, and we need to work on that. But also we need to remember the 4 A's related to technology if we are working in the field. Is availability, accessibility, affordability, and acceptability. And those 4 A's change depending upon the region, upon the country, and upon the local place where we are working. So we need to have all these elements in mind when we are working, but we need definitely to continue advancing. We now have a baseline, and from there we could start moving forward and measure our advance, but always with a strong support of the community. In that way, probably we could implement or help to implement programs, and we could scale up solutions based in the local and specific situation of institutions, organizations, and countries. Thank you. That is what I want to share with you today. But also remember what all of our mentor was always telling: if you could not measure, you could not manage. That is a basic principle in management, and that was Bob Morris. We remember him quite frequently too. Thank you.
A very rich set of comments. We have to align our work with national priorities. We have to figure out ways to scale up. We have to be influencers, leader mentors as directed by our brother on the screen there, and then the 4 A's. Yep, got to do all that. Toby, take it away.
Yeah, that was very important statements that you made, Antonio. You know, in terms of the, the survey, I think it's, and the framework is really set up, through very thoughtful work by everyone that was involved in that, Shauna and others, Fabiola. And, the data that comes in, there are some data that comes in that, really affects common problems globally. I think we can take large data sets such as Zenhum and others have put together from China. But, I think one thing that I'm wondering if, and I'm not sure how to measure this, but is really vitally important is the leadership aspect that Antonio brought up. With examples such as Adriana Velasquez, certainly, and the work that has been done in India. All of that shows the impact of leadership, and that if there was, the only area I think that sort of fits into is on the bottom of that chart that you showed, Tom, you know, the competencies and the, you know, the societies that have been set up, et cetera, et cetera. But, you know, things, the context is important, and Fabiola brought up the importance of that, but that context really, if it's a difficult context, that is so well enhanced through leadership and mentorship that Antonio brought up. So, you know, certainly myself working in the Caribbean, it's a very unique context in that it's, you know, a series of islands and small nations. And, you know, the difficulties that arise there are quite different than would arise in US, Europe, even Mexico or Brazil or many other countries. But the leadership that had been put forth in several countries that I've worked with, certainly Paul Taylor, as I mentioned, in Trinidad and Tobago, has really pulled together a network and developed capacity building and you know, cohesion in that country. As was discussed, Evanel Oasis in Haiti, which is undergoing a very difficult time. But others, just to mention, Greg Cabral in Belize has, that you don't hear too much about Belize, very small country, but he's really been able to bring together the HTM people in that country. And Jamaica, Marlon Jones and Conchita Liebert are really doing a great job with the Ministry of Health from the clinical engineering standpoint, but that's supplemented through the Chief Technology Officer there, Maureen Golding, who is really bringing it beyond clinical engineering to look at the importance of regulation and HTA and an integrated program of health technology assessment. So I just wanted to bring up the point that, you know, leadership and mentorship are just so important. And I wish there was some way that that could be looked at in terms of the case studies and the assessments that we're doing. Over.
So Toby, just reminding us about context, reminding us about what Antonio said about influence, and how influence connects with politics. And I know in the Q&A, I saw Roberto's comments about, he reminded us another aspect of the complexity of changing Mexico because of politics. And you also talked about how HTA, health technology assessment, health technology regulation, I like to call HTR, and HTM, health technology management, our work, how they often can be combined to get more bang for our buck. All very good things. Over to you, Rosanna.
I would like to address regarding one of the questions from the attendees, how to improve the visibility and the role of the clinical engineers out of the side of the maintenance or repairment issues. And I would like to go back again, not just to the leadership, but leadership, maybe leadership aimed to outputs, leadership to change, and also training as a way also to improve these skills in short term. I believe that the BOK could be improved if the contents also include methods and models, best practices in how to approach and make possible the thinking in a strategic way, system thinking, design thinking, to make a more high impact hour, because I will say hour myself to be better. I should learn by myself. I'm looking, observing around myself, other leaders, how to improve rapidly what I am doing. So these contents, a strategic approach, leadership, but leadership aim to results, outputs, a negotiation, how to be a good party, the other side of the table, but not just to make contracts, also to support and to improve decision-making processes, could be valuable context for us to improve what we are doing in the site. Although we are not yet in the position in the job we would like to, if we have this context included, this could be a way, a short-term bridge for us to change. Mario Castañeda always, I have the privilege to be close to him among the years, and one of the valuable, very valuable advices he provided me was about leadership by results. And he told me that instead of thinking about things I am not able to do yet, think about things I am able to do and how to improve them enough to make it visible and valuable for others. And in that regard, I am smiling because it's a sort of a joke, not a joke, but it's sort of a joke. He used to say, Mija, the problem with you is you hate the money. The money is not a bad issue. You need money. You always think about quality and benefit for the people and the population, but you need money also. So please think about the money in a way to improve the quality and the issues. And I take this time to say how much he improved my leadership, not just as an engineer, but as a woman as well. Thank you, Tom.
Very good. We've got 25 minutes left. So I think we've been working on these next steps, the new next steps, as we've been talking here. And obviously we've recorded this, and we'll try to fill in some of these next steps over the next few weeks by listening to this, listening to what you said today. We've got some time to share a few more. We've certainly talked about the framework. We've talked about some of the early results. You have access to this document I'm looking at. If you go to the 4 meetings announcement, there's 9 active links at the bottom of it that has a lot of the documents, and this one that we've been looking at on this meeting, and that we'll be looking at in the town halls the next 2 days. Tomorrow, credentialing led by Toby Clark and Fabiola, and then Thursday, Elliot Sloan, who's here, and Fabiola and others on. So, and I think, develop awareness for health leaders for capacity building through WHO is certainly one of the strategies. We talk about leadership and influence. Certainly the bosses on both the ministers of health on the public side, the universities and others on the NGOs on the private side, they listen to WHO and they listen to PAHO in the Americas. They listen to the Afro regional office. Anyway, by the regions, they listen to both Geneva and they listen to the regional office, for their own set of countries, for their own regions. We've got a growing amount of tools to be able to develop awareness. Toby, I'm going to ask you about this in a moment. You and Bill Gentles led 100 people for over 2 years, developing these, 23 WHO medical device related and management related COVID training videos, now being translated into probably 10 different languages. How can we use those tools to create awareness for health leaders that WHO cares about this? WHO is leading an effort in the CE/HTM biomedical engineering space. And how can that educate them? Maybe you use these tools in Caribbean work, as you've been talking about, Toby. Or maybe this creates an opportunity, having those tools to go create regional and country level webinars and use online training like the 60 programs that CED and GCA have put together, like the training that you do, Toby. So is item number 3 here on the screen, how's that working for you? Have you been able to use those tools to do capacity building in the Caribbean?
Well,
How can we help you if you need any help? I don't think
certainly. there's almost 14,000 people that have signed up for the set of videos, and there's actually about 35 that are available at this point.
Cool.
And that has been made aware. We've made the individuals in the Caribbean and the PAHO nations in general aware of those videos through PAHO's Alexandra Lemgruber and others in the office. You know, they're very important. One important aspect is that they show the life cycle of the technology. So they cover from you know, basically the acquisition point right through the decommissioning and disposal. One important thing, I just want to bring this up, is that Humatech in France has been working with WHO to come up with a really robust donation policy, which, you know, I found particularly in the Caribbean is a big problem area where clinical engineering can be very valuable. I just want to mention that should be out certainly before the end of the year. But to go back to the, you know, I think virtual training in general is valuable because of the access, and if it's of high quality, it can, you know, really be impacting.
Very good. Yeah, Humatem has been working on the donation issue for years out of France, but really, you know, what's their scope of influence? And it's very wide. As think French-speaking countries around the world, and there's about 40 of them, and they really are very focused on helping not only France, but particularly sub-Saharan Africa and places like Haiti and so forth. So very good suggestion and we know many countries are very donation driven just by their nature. All right. Identifying and working with key healthcare influencers, you know, across the stakeholder spectrum. Are there other thoughts from the panelists? I guess we're having trouble promoting participants to the panelist level. Sorry about that today. Maybe we can improve that for the next 2 days in the other town halls. But how can we, I mean, we've already expressed some ideas. You know, we need to work with people to put the BOK survey findings into context. And by the way, I think others have said the body of knowledge is pretty common around the world. It's pretty similar, but the body of practice differs widely. And so that's what we're focusing on. We heard several speakers led by Antonio talk about, you know, we're not going to get attention to our work unless we use them to address health priorities in the country. Certainly COVID is one of those priorities, but there's, you know, in some countries it's maternal child health, and others it's chronic disease. You know, we need to be smart about that. You know, to the extent that our work can help strategize, as Rosanna's talked about, on finance and funding challenges. And I know Antonio, if he had the mic longer, would talk about the way, you know, governments change, ministers of health change, but universities that support healthcare, public and private in countries, often remain. And so that continuity, it shows that it's wise for us to find ways to partner with universities. Thoughts from the panelists on these things? I mean, I think this is what you panelists have said to us before. Any new thoughts on that, of how we can actually do it, or any examples of how we can do it?
Tom?
Yeah.
Toby mentioned something that is relevant and from time to time always come to the table: donations. And, you know, we have been working in this since the 90s, and with the ACCE guideline, the Orbis guideline, and then WHO guidelines for donation. However, the next step is the assessment of the donations. Back like 6 years ago, I did the work for PAHO and prepared a methodology for the assessment of donation, and I did the assessment in 3 or 4 countries. And I think that instrument that has not been used anymore is a tool that could be included in our toolbox of methodologies if you want to use it. Being PAHO product is open available.
Very good. I see that we've opened the mics for some of the attendees. Iwa, you've been wanting to speak for a while. Can you go first? And maybe Elliot? And then Emmanuel? So you can open your mic, Iwa, and speak, I believe, from Poland.
Oh, okay. Thank you very much. Thank you very much. I'm sorry, but I was not able to answer. But generally speaking, the capacity building in Poland is not growing up significantly, but we are just working on. So we collect, first of all, I collect information from a meeting with you. And I believe that we will be able to organize clinical engineering in our healthcare system on the high level. So it's my plan, and I do all my efforts to realize this work. First step, I think, because actually I have written in our reports previously that actually we, one may say, we do not have capacity building because there are only few clinical engineers working in our health system, because there is in organization of the system, there is no clear, there are not clear tasks, and there are no clear area for clinical engineering. So we have only people who make care of service, but it is not an organization. But
so Eva, if you've heard a lot over the months and today, is there one step that you think would make a difference for Poland? I mean, what's your first step? What do you think? I mean, and I know it's not just you, it's us helping you and thinking with you, but.
Yes, but what we are planning to do is go two parallel ways. So one is efforts in organization to change legislation and to reserve place in organization of healthcare system for clinical engineers. And second one is education, because those two processes may go parallelly. So it is the plan.
Very good. For time, let's move. Elliot, open your mic.
Okay. Thank
yes,
you.
hi. Can you hear me okay?
Yeah.
Well, I mean, this is a long journey, and I think we're making great progress, and certainly it is invaluable to be able to look over the horizon at the accomplishments of our colleagues around the globe. In fact, perhaps there is a very near-term need or opportunity to generate an article or two for the Clinical Engineering Journal to document these things. I think that there's, certainly one of the elephants in the room is digital health, and it's an area that we all kind of know because we carry smartphones and we work with computers, but it really is changing a lot of the landscape of medical care. And you mentioned the case study of the pulse oximetry at home program that the UK developed. Figuring out how to get ourselves as a community even more actively involved in that discussion is an interesting challenge and a huge opportunity. It also kind of hidden in there is the fact that 10 years ago, when I was speaking in the Middle East, in Latin America, in Europe, my colleagues said, well, we don't do home care. It's not our tradition. The reality is that everybody is now doing home care. And our field, our colleagues tend to have blinders. And I've been having this discussion, sorry, for 2 decades since I left Medic, where we had nearly half of our fleet of medical devices being used in home settings. That's a different skill set. It's a different set of priorities. Of course, there is an overlap. An infusion pump still needs to be safe. A ventilator still needs oxygen and compressed air. Those are the technical parts. So I think there's a lot that we, there's a lot that we should be looking at as we not just talk about capacity building in today's framework, but capacity building for 2030. And it's on us. Nobody else is going to do that for us.
Good word, Elliot. I know Toby and Rosanna and Antonio were talking about hitting on the right health priorities with the health leaders. Certainly digital health is one of those hot buttons. By the way, just an FYI, Elliot worked in Saudi Arabia in years past, and they champion digital health and EMR driven work and devices integrating interoperability. So that was a hot button in the Middle East, North Africa, IMRO region. We're starting discussions with the Ministry of Health Morocco. We're starting discussions with the former Ministry of Health Afghanistan. We've got links actually into North Korea's healthcare leadership. We've got working with Tazeen Bukhari in Pakistan. The hot button there is oxygen and regulation of devices. So with the voice, with the Ministry of Health and WHO. So we need to all strive to find ways to touch on that. Emmanuel from, I believe, Rwanda, you want to speak? Briefly, please, sir. Time's running out. So Emmanuel, you can open your mic and speak. While he's doing that, I want you all to hear about an announcement that was made at the Global Clinical Engineering Alliance meeting yesterday by Yadin David, and that is GCEA, really representing also CED and AAMI, our favorite Amy, have just signed an agreement to help one another create educational tools around the world and to push existing tools, but also create new ones. And they actually have a TV recording studio now at Amy's headquarters there near Washington, D.C. So what an exciting new opportunity for us to work around educational tools around the world. One of the questions that Antonio and Elliot drive us to look at is what alliances can we create now? I've just answered with one of them, but what are other ones that we need to think about? Shauna, I'm going to look in our remaining minutes here at the impact analysis work. We've talked earlier about people are taking the survey and that numbers are growing. Exciting about that. It's got all these elements in there: access, quality, safety, efficiency, digital health, cyber. Those are places where we're making longer term impact, telling stories, considering regional differences, aligning this work as people like Milad and Paluta have reminded us, our work with what WHO's models are. This is the ministers of health talk. This is the health leader talk. Affordability, access, and availability, and what else did I forget? You were talking about acceptability, if it's not there. Antonio, what do we link with that's important to our countries? And Antonio reminded us, the 1993 PAHO document that looked at the 25 years coming up into the early 90s, and then the work of several of us that was published about 1990s to 2015 with the work of the Advanced Clinical Engineering Workshops and how that impacted countries. So we can get historical impact. Are there other next steps that you're thinking about after hearing all this, Shauna, for yours and Saba's and others' work?
Yeah, we talked about next steps as we're getting more and more responses to the survey, which is great. So the first next steps are to do some general narrative statistics. So what responses have come in from which regions, what types of impact are they broadly grouped by? So the kind of overview, the narrative description of the data that's come in. And we talked also, Elliot, you'd mentioned a submission to the Global Clinical Engineering Journal. We'd actually had a chat about that, Saba and I, a few days ago. It would be great to engage someone to do kind of vignettes from the submission. So small, short descriptive stories for each submission, and then a macro theory of change based on those. That show the impact pathways between the stories. So that's what we were thinking for that. Now, after this session today, which has been really good, I'm also thinking it would be useful for us to, again, revisit the kind of linkages between what's there, what exists with the capacity building model and the information about different places with the data that we're getting in from the Theory of Change survey. And I just want to reiterate to everyone that we do have the survey open still. And even if what you're submitting to us is just an article or a link to an overview without filling in the actual information in a structured way in the survey, that's still great. So yeah, I think it would be really interesting to link those two things. And then I was also thinking donations is a subject that's very near and dear to my heart. And it's great to hear, Toby, that Humatem is, that is going to be out very soon. That's quite exciting. And it got me thinking that maybe, and this is further down the line, but maybe one of the future phases for this project is once we have the kind of overview set up and the methodologies clear, and we have some initial results that we've put out there in the world, maybe through the journal, that we could actually ask for, we could use this framework to ask for specific impact stories on a particular subject. So for example, around donations, we could ask specifically through the IFMBE, the GCEA, and other kind of global communities, tell us your impact stories related to donations. So we could, if this looks like this model is kind of working well for sharing those stories or describing the impact our profession is having, we could do specific calls on different themes. But that's me thinking way far into the future now.
Very good. Xing Kun, Alan.
Thank you, Tom. I just suggest the capacity building projects. We may need invite some of the industry to introduce some of the emerging technology in the horizon. And the second one is we clinical engineers and technicians should be prepared for the new technology, how to do the quality control, such as for the software as medical device, and also some of the AR, as more and more software as medical device and AR finds wider application in the hospitals. And we need to be prepared how to do the quality control, how to measure it. Yeah, so I just suggest to end these two topics as capacity building. I think it should be kind of universal. Yeah, thank you.
Thank you, Alan. Just a quick aside, one of our sponsors a year ago was Helium, and it's led by one of our outstanding, happens to be woman clinical engineers who's turned to industry in the IT digital health industry for the last 20 years, Carla Gallegos. She and her team were sharing with Dr. David and I, and really in the past week, where this new tool that, basically you can, anybody anywhere in the world can choose among several doctors and get a visit on a virtual visit within 15 minutes, where they're pulling from data sources, EMRs and other things, through various API-driven connections, and they can pull your data from anywhere and everywhere just about, and they can put that through AI, put it through live physicians, that you choose which one, and you can have a virtual visit. I mean, we're enabling virtual care around the world with emerging technology tools, some of which are very medical device and digital health that, you know, we control related, some of which are, you know, a little beyond our ability, but we can enable this kind of virtual care around the world. I know Elliot Sloan could talk about that for an hour in a very cool way, how that's happening. So yes, so partner with people that are going to make a difference in these key areas that affect patient outcomes. I'm just giving an example of Jinkun, aka Alan's great idea there. We're out of time. Any closing comment, Fabiola, possibly Antonio?
Well, I think it has been a very productive morning. We have expressed all the most significant points that were released once we got some very valuable information. And the next steps are getting clearer, but we have to be aware of what we have commented here, what Toby said and what Antonio said. We have to take action very carefully, thinking of that we are going to do now. We definitely will have an impact on our college, but also on our health system. So let's move forward. Thank you so much.
And Fabi, just so that you and I are not overwhelmed by the tidal wave here, is one step at a time. You know, our sister Adriana, you know, never give up, one step at a time. Antonio and Rosanna, close us out.
Yeah, I have
Thank
a
you.
last.
Thank you. Please, Antonio. Please.
I'm sorry, Antonio was going first. Go ahead.
No, go ahead,
Okay.
Roxana.
But he's such a
No,
gallant
Antonio.
person.
No,
he's giving it to you.
The captain Tom says you first. I wait.
Okay, I will be very quickly, and my last comment is based in what Iwa from Poland was telling, how to negotiate, how to deal locally when you are trying to advance a health technology program. And I always remind everyone that all countries, ministries of health, government, accept and sign the WHO resolutions related to health technology. That is a political instrument where the governments accept and adopt those decisions. So with that instrument, you could go to your authorities or let them know that the country signed this and commit the country to advance this program. That is a very important political tool to be used in the negotiations. Thank you, and wonderful meeting.
Go ahead, Rosanna.
To provide a last advice is about improvement of outputs expected in capacity building project. In the country, in Peru, we identified 2 regions who have been making results beyond the challenges and beyond the restrictions. And both of them are focused on digital health. One of them is making in parallel infrastructure with digital health support, improvement of quality of services with the digital health support, etc. So we're going to take these 2 cases to make the next steps regarding capacity building. I believe that this is something that could also work in the sense of the contents of this project of capacity buildings and high impact outputs. Finally, thank you very much.
So Rosanna, please share those with us, but keep going.
Thank you very much for the opportunity to make this session so insightful and really valuable opportunity to exchange and discuss with such distinguished colleagues. Thank you.
Eva, do you have a comment for us as we end?
Thank you. I would like only to shortly answer to Antonio, because of course you are right. It's also political problem, but not only. Mainly it is economical problem, and maybe in our country it is much more complicated. But I believe we will find a way, and we will propose solutions which will be accepted, and then we can go forward. Thank you very much.
Wonderful expression at the end. We will find a way. Thank you, everybody.
Thanks. Bye.
Thank
See you tomorrow.
Bye-bye.
Thank you. Bye.
Thank you very much. Bye-bye.
Hi, everyone.